So next we're going to talk about 1-03, which is the IV protocol. We'll start kind of with just your general indications for an IV because this is part of the universal care section. It's something that should be considered on every single patient, but most patients, frankly, probably don't need IV access in the field. Really, the only indications for IV access is either the need for medication to be delivered in the field or fluids to be delivered in the field. And if your patient doesn't need medicines and doesn't need fluids, then really they don't need an IV in the field. Now, the other side of that though is if this is something that is going to help the receiving facility or the ER expedite care or just help them out to where they're not having to take the time to put an IV in, then you can absolutely attempt a peripheral IV in the field as long as it's not impeding our transport to the hospital. Now, as far as kind of the guideline itself goes, we start up here. Obviously, this as part of the universal care guidelines is going to be second to kind of your airway access, but we start kind of with the cardiac arrest here. And in a patient with cardiac arrest, we generally recommend going straight to a IO access, be it tibial IO or humeral IO right now, or possibly other sites in the future. If they're not in arrest, then we talk about considering peripheral IV placement. And as we talked about, if they don't need it, you don't even need to try necessarily. But if they need it, then the first step is obviously if it's successful, great. We're going to sit here. We're going to monitor, have the EMT monitor an INT. Obviously, if fluids are going, that an AEMT or higher needs to be monitoring that. And the type of fluids down here at the bottom really is going to be more dependent on the patient's presentation and more with the guideline that you're going to be using in further sections. But in general, if they need fluids, we don't run maintenance fluids in the pre-hospital setting. If they need fluids, we need to bolus them, and that can be in small increments. Generally we're going to do between 250 and 500 mLs in most patients, up to a full liter in patients with substantially abnormal vital signs or presentations, and reevaluate and continue that as needed. The other option, obviously, is your TKO or INT. If they don't need fluids, then you can run a TKO rate of fluids, or just flush it and keep it as an INT to use for medication delivery. And then obviously, that last part over here is whatever is directed by a specific guideline. Now, if you're not successful though, and that kind of gets us here into the center, is if you're unsuccessful, after 3 attempts, then we need to look and see if this is something who really needs an IV that minute. Now, if they're stable, meaning they don't need an immediate life-saving medication or treatment, then you can consider alternative routes of treatment. They can wait to get to the ER. You can try nasal medication, intramuscular medication, oral medication. Considering alternative ways of treating your patient. But if they're unstable, meaning they have some sort of acute life-threatening event that needs immediate, IV medication or IV fluids, then the paramedic can obviously look at placing an EJ or external jugular IV, or placing a intraosseous line. So, if there's any questions, please let me know, and thank you for your time.